Hello, everybody. It's nice to be a part of this fantastic conference again, although I wish I was seeing everybody in Salt Lake City. It's a pleasure to be a part of the Cholangiocarcinoma Foundation meeting. My name is Ryan C. Fields. I'm the Chief of Surgical Oncology at Washington University in St. Louis and the Alvin J. Siteman Cancer Center, and I'll be speaking today about the definition of perihilar cholangiocarcinoma. I have no disclosures or conflicts of interest and won't discuss any off-label uses. And I would like to thank someone you all know well, Dr. Flavio Roca, for the use of some of his slides in this talk today. So why is this important? Why do we need to define perihilar cholangiocarcinoma? Well, I turn to the word precise, and that's because we need to be precise in order to do all the things we'd like to do to advance the field of cholangiocarcinoma. And that's because we really need to give exact and detailed information about these tumors, because cholangiocarcinoma by its single word origin and varied nature is not precise. It's not precise because what we really want to know is, are we talking about intrahepatic or extrahepatic cholangiocarcinomas? Are we talking about distal or proximal cholangiocarcinomas? Are we talking about mass forming or infiltrating cholangiocarcinomas? Locally advanced or resectable tumors? Are these periambulary? Are they around the gallbladder, where some of these definitions can blur even further? And does this all matter? Does it matter in terms of outcome? Does it matter in terms of staging? Well, yes, it matters absolutely. There's differences in surgical approaches with different morbidities and mortalities. Sometimes we're talking about doing a liver resection, sometimes a pancreatic duodenectomy, sometimes both. Every once in a while, a limited bile duct resection. All these things are very different. There are genomic differences, which I'll allude to. That's exceptionally important in terms of treatment and prognosis. With respect to how we treat these with chemotherapy, targeted therapy, immune therapy, and all these lead to different outcomes. So we need to be precise, and we need to be precise in these definitions, if for nothing else than to stratify patients for studies where they can be placed in uniform categories so we can learn something about what we're doing. So I could put a number of examples up, but I really like this study back from 2017 that was published in Clinical Cancer Research, or I'm sorry, in Cancer Discovery, that looked at one of the first studies to look at whole genome and epigenomic landscapes of distinct subtypes of cholangiocarcinoma. And I've put the reference here, and I'm going to show one figure, and it's a busy figure, but what I'll point to is if we start in the upper left, we look at these clusters of cholangiocarcinoma, fluke associated and non-fluke associated. If we look here at location, different locations cluster together of cholangiocarcinoma with different subtypes. We see differences in microsite satellite instability, in association with hepatitis and PSC, in different countries of origin that oftentimes corresponds with fluke infestation. And if we look further down, very different clusters with respect to common genomic mutations, some of which are actionable. We all know about FGFR mutations and IDH1 mutations, and so these are dramatically important. And if we look at things like PD-L1 expression stratified by these different clusters and subtypes, if we look at outcomes with respect to these clusters in terms of survival differences. So genomics certainly matters. I know I don't need to preach this to this audience and the Cholangiocarcinoma Foundation that's been so instrumental in providing advocacy for sequencing of cholangiocarcinoma, but it certainly makes a difference. So how are we going to define cholangiocarcinoma? Well, the original system published by Dr. Bismuth back in 1975 with the Bismuth classification system really looked at the relationship of the tumor to the biliary confluence, and we had types 1 through 4 with 2 categories in type 3. Type 1 tumors were below the confluence, so limited to the bile duct outside of the bifurcation of the left and right duct. Type 2 were really confined to the confluence, and what confined really meant was not extending up far into the right and left ducts, as you can see in type 3 and 4, depending on whether it was right or left. And then type 4 was really extensive disease into the right and left hepatic ducts with multifocal bile duct tumors. This was important and got at the idea of resectability, but it was still very difficult. This is a pathologic diagnosis in a lot of ways, because very hard sometimes to make these diagnoses radiographically, because sometimes, especially in the setting of something like PSC, the strictures in the radiographic appearance may not correspond to the extent of tumor infiltration. What we really think about as surgeons is the anatomical considerations of how we approach cholangiocarcinoma when it's in the hilum. And that's because the bile duct shown here more in a cross section, so this is segment 4 of the liver, more anteriorly and superiorly, segment 1, the caudate lobe, below that, so towards the patient's posterior. The bile duct is right up against the portal vein and the hepatic artery, and as you move up and down, this hepatic artery courses underneath the bile duct. So vascular involvement is key. A lot of times these small tumors are an issue of really geography and not geometry, in the sense of they're not big tumors per se, they're just in an area where resection would compromise liver function and liver flow, which is of course why we talk about liver transplantation as a therapy for a select group of these patients. So if we really move forward to the main clinical staging system we use now, that is the pre-treatment staging system. It's really the Blumgart clinical staging system, where we separate tumors into T1, T2, and T3. T1 tumors involving the biliary confluence with unilateral extension to secondary biliary radicals without vascular involvement, such that we can remove that part of the liver with its corresponding, obviously, biliary and vascular supply, but with a remnant liver, sometimes needing to be induced by hypertrophy methods, but a remnant liver that can serve as that patient's functional liver afterwards. T2 tumors in this classification system involve the confluence with unilateral extension to secondary biliary radicals with either ipsilateral portal vein involvement or ipsilateral hypertrophy, atrophy of the liver. What that means is there's vascular involvement to the side where the tumor is, still allowing us to resect the majority of these tumors. Sometimes if the portal vein is involved, close to the confluence with portal vein reconstruction or resection. But again, because it's unilateral in that sense, still resectable. So T1 and T2 tumors are resectable tumors. T3 tumors are where we get into more advanced tumors, typically not resectable. And this is due to bilateral involvement up to secondary biliary radicals, or unilateral extension to secondary biliary radicals, but with contralateral portal vein involvement, or unilateral involvement with hypertrophy of the contralateral lobe and main portal vein involvement, sometimes, which can be resectable. And of course, we do push the limits of this sometimes in the sense of resections with more involved vascular reconstructions. As the surgical techniques and ability to do this safely has been advanced, we've been able to do push this to some degree. If we look at outcomes with respect to this staging system, this is a report published in 2012 by the group at Memorial Sloan Kettering. And you can see Dr. Roca, who I mentioned earlier, was an author on this paper, along with a number of other people that are familiar to this audience. But this looked at 380 patients by T1, T2, and T3 Blumgart stratification. And you can see the overall survival for patients was 19.4 months for all patients, with a 15% 5-year survival. Of those patients that were resected, a 39-month median survival. And if we look at this by T1, T2, and T3, you can see that the T1 patients did the best. T2 patients still had reasonable survival and outcomes, especially if they achieved an R0 resection. But really in the T3 patients, even in the one patient that was resected, you can see that's where we sort of fall off in the sense of this clinical staging system really showing its power. If we then look at this staging system applied to other centers, this is a report from the Journal of Hepatobiliary and Pancreatic Sciences from 2020. So looking at a modern cohort of a group from a Japanese cohort of patients. And you can see in a large study, over 500 patients stratified by Blumgart classification, you see the same patterns emerge. So this clinical staging system works very well to stratify patients in terms of outcome after resection. I'm going to shift topics. We've sort of gone over the definition of perihilar cholangiocarcinoma to the role of lymphadenectomy. And the reason I bring this up is I do think it's important in the definition in terms of preoperative, but also in terms of staging for adjuvant therapy and what we think about as a regional lymphadenectomy. So Tim Pollack and others have really stressed the importance of lymphadenectomy in cholangiocarcinoma. We think of the N1 nodes that would typically be removed with a resection involving the nodes surrounding the portal vein, common hepatic artery, and cystic and common hepatic ducts shown in blue in this schematic. Whereas N2 nodes that are retropancreatic, aortocaval, celiac, and superior mesenteric arteries, these are really stage 4 disease. If nodes are involved in this area, and we can show that on imaging and EUS sampling preoperatively, these are not the patients we should be operating on. And this has been incorporated into the staging system in AJCC8. You can see some differences in terms of lymph node positivity and where these nodes are located and what they're considered. And again, I think this is important. This has been shown to be important in terms of staging and definitions of resectability. Again, if we then look at staging by the AJCC categories and look at lymph nodes as predictors of outcomes, you can see this has been incorporated into the staging system and also corresponds to outcomes. So I was tasked with a relatively easy and I would say precise topic, and that is to define perihilar cholangiocarcinoma. We'll use this, I think, as a starting ground for some of the other talks, looking at radiographic definitions and how this impacts treatment decisions. Once again, I'd like to thank the organizers for the opportunity to speak, and looking forward to continuing a great conference. Thank you very much.